This presentation is Impact of the Affordable Health Care Act on Healthcare Utilization in Populations at High Risk for Cardiovascular Disease in the United States, an NHANES study, by Group 3, Catherine, John, and Danielle. So starting with some background on cardiovascular disease, 1 in 4 deaths in the United States is due to a heart disease. Cardiovascular disease frequently results in needing specialized or ongoing care from a physician, which in turn impacts the healthcare utilization of these patients. Cardiovascular disease also makes up a significant percentage of healthcare utilization and costs in the United States. Some cardiovascular disease risk factors include diabetes, being overweight or obese, having high blood pressure, which could mean having a systolic BP of over 140, or a diastolic BP over 90, or having dyslipidemia, which means having HDL cholesterol levels less than 40 milligrams per deciliter, LDL cholesterol levels over 160 milligrams per deciliter, or having triglyceride or total cholesterol levels over 200 milligrams per deciliter. So some background on the Affordable Care Act. The Affordable Care Act became law in March 2010. Its explicit goals were to expand healthcare coverage, hold insurance companies accountable, lower healthcare costs, provide more healthcare choices, and improve the quality of healthcare for all Americans. So for our study, we posed the research question, did the Affordable Care Act change healthcare utilization for those at high risk for cardiovascular disease? In order to research our question, we utilized the National Health and Nutrition Examination Survey. NHANES conducts surveys and medical examinations to assess the health and nutrition of the U.S. population. Its participants are considered to be a representative sample of those living in the U.S. It's done every 2 years and is a public data set, meaning that it can be used for secondary data analysis, which is what we've done here in this study. On the NHANES website, you can access all the data they have available for the study from 1999 onwards. There are actually more data available from before this date, but the variables are not continuous year to year. So after clicking on a section you would like to review, you come across to an area where you can select specific variables. So here we've gone into the laboratory data. So for each laboratory data set, there is a data file for download and a codebook explaining all the variables. Any of these can be downloaded for analysis. When using the NHANES data, it is important to consider the definitions of the variables provided, the methodology behind the survey itself, and what has changed in the survey over the years. This information is all available from the NHANES website. So for our study, we looked at a population of adults 40 years or older that all qualified as high risk for CVD participants based on the previous CVD risk factors we defined. This meant that we had 2,903 participants from the 2007-2008 data sets and 2,621 participants from the 2013 and 2014 data set. We picked these two data sets as they fall on either side of the ACA implementation. We created a new binary variable from the NHANES data that we call healthcare utilization. This variable defined high healthcare utilization as 4 or more healthcare visits in the past year, and normal or low healthcare utilization as less than 4 healthcare visits in the past year. We determined the cutoff by looking at where the majority of both data sets lay. This variable was created using another variable in the NHANES data set, which was number of healthcare visits in the past year. In our statistical analysis, we modeled the association between the ACA and healthcare utilization using multivariate logistic regression, tailored to the survey data protocols. There are some idiosyncrasies involved in working with survey data due to the manner in which it's collected, so it was important to take these into account during analysis. Our primary independent or exposure variable was the implementation of the Affordable Care Act. Covariates that we controlled for due to their potential for confounding were age, race, ethnicity, gender, and health insurance status. Our outcome of interest or dependent variable was healthcare utilization. Our results demonstrated a significant difference in age, race, many of the cardiovascular risk factors and healthcare utilization between the pre and post ACA time periods, we found that participants at high risk for cardiovascular disease were approximately 2.3 times more likely to have high healthcare utilization after the implementation of the ACA. Our accrued and adjusted odds ratios were almost identical, indicating that the association that we found is valid. Our results demonstrated a positive association between high healthcare utilization and the implementation of the ACA. This may be a result of the ACA's focus on preventative care and routine screenings, meaning participants are seeing their doctor more frequently. Women were also seen to have a higher healthcare utilization compared to men. Race, however, was not a significant predictor of healthcare utilization. The strength of this investigation stems from the utilization of a large, diverse, nationally representative sample from NHANES. While this investigation researched the association between ACA implementation and healthcare utilization in the population at high risk for CVD, this can be extrapolated to those with chronic disease. We can propose that access to care for those with chronic diseases increased because of the ACA. Thank you for listening to this presentation. If you're interested in looking into secondary data set analysis, a lot of information about available data and how to use it can be found on the NHANES website.